I've been introduced before. This is Dr. Albert Chinappi, an orthodontist, who also practices his practice is about a block away from my practice. We met in 1980. We've been good friends and colleagues ever since. This picture is taken with Dr. DeJarnett in 1984. And I thought it would be appropriate, since we're starting with Dr. DeJarnett, to read a little bit of a page 192 out of his 1979 cranial technique book. There are 3 sutural systems in man's makeup: the craniofacial types, the weight-bearing sacroiliac types, the alveolar of the maxilla types. Okay? With the above in mind, recognize that one sutural system cannot be independent of the other. The category 2 is, for those that don't know, category 2 is probably the most patients are category 2. The category 2 is basically a pelvic problem, but it may and often precipitated by the maxilla or a cranial sutural problem. You cannot correct the craniofacial suture system until you are certain that pelvic sacroiliac, and it goes on and on. But he looks at the most essential, almost essential, that the category 2 be managed with dental care. I'm having trouble reading this because it's so dark in here. But the essence of this is that it's okay. It's okay, Charles. It's okay. I don't have to go on. But the essence of it is that the DeJarnett truly saw the need of the combined care, especially in category 2s, which is our most populated, most patients that we see.
For the young folks in this audience, which is mostly everybody but us.
Right.
What year did you invite me to the first meeting?
Well, I think in the early 80s, I would say 82.
Now, for your benefit, in 1977, I got very frustrated with traditional orthodontics, started doing functional orthodontics. Harvey and I met in study club. We had study clubs in our area for TMJ. That's when John Witzik appeared in my life, and I ended up going with Tufts to the dental schools in Europe, ended up at Tufts University, at Frankfurt University in Germany, and came back and converted the practice to a functional practice. Harvey and I started working together on patients, co-treating patients, and my first experience at Sorcy was a meeting where the major, the good-looking guy on the right, on your left, I mean, he talked about the importance of dentistry in chiropractic care. And I'm looking at the changes that I'm making functionally, structurally in patients, and afraid that I'm so outside the box of dentistry, I don't want to talk about it. And the major was defining the need for the services that I was developing in my practice, and that's how we got together. Mm-hmm. And we started sending patients back and forth. You have to show Exhibit A.
Well, Charles wanted us to talk about the early years, and for many years, we used an envelope like this that, and this is one of them, has a patient's name up here, where we put information. When I would adjust somebody that was going down to see Al, I would make some comments and some notes. The patient would carry it from office to office, and he would send it back. We dated it, and we used this for probably a handful, half a dozen years. Yeah.
That's how he learned chiropractic.
A lot of patients. The patient was a carrier. They would hand us the envelope, and I would read the latest. We were learning. We were early learners at that stage, and the information was critical. Now, you know, I think Al made the comment within the last couple of years that now we see it as we're climbing a wall. He's on a ladder down there, and I'm a ladder up there. We'll meet at the top because we know each other so well, and we do, as it says in the paper. If there is a problem, we communicate. But basically now, we understand each other's work so well that we can just move through it.
Why is this not? Oh, here.
Yeah.
So Charles asked us, this is going to be a dog and pony show. You get the tag team thing here. It's going to be kind of fun. Charles asked Harvey to review a paper that we had published in JMPT, the referee journal, in 94. And the way that started was I became a regular at Sorcy's conferences in Omaha, and I would speak at the cranial meetings, and Harvey would teach, and I would teach, and we would talk about facial growth and development and its importance in terms of chiropractic care. And there was an editor from JMPT there, and he wanted to have dinner with us and said, you guys have to publish something. Well, we published a commentary. We couldn't do research. It had to be a commentary. So that was the first article that we published in 1994. And the title was A New Management Model for Treating Structural-Based Disorders, Dental, Orthopedic, and Chiropractic Co-Treatment.
Yeah. Yeah, Al?
Yeah.
As Charles has said, that article, by the way, is all these 3 articles are published in the book that Charles supplied us with.
Great.
Yeah.
So we come up with this little chart. 1982 was the birth date of chirodontics or orthopractic. I'm not quite sure which term we all want to use, but that's when we really started looking at each other's information and technologies. The first article was in 94. 95 was a follow-up article because the editors now had a concept around which they were comfortable, and we presented 2 case studies. And you have those in your packets. The case study on cervical spine and one on lumbosacral pain. And which brings us to 2015, this review for this organization.
Interesting, the 95 and 96 article was one patient. The 95 article, case study of the cervical spine, was a patient that was being treated at Al's office for a while that he felt needed more, and was sent to my office. The second case was a patient that I was adjusting that I felt needed more, and we sent it, and I sent her to Al's office. Both of these articles, which are in the book, am I right? All 3 articles are in the book. Have some really outstanding, in my opinion, X-ray findings pre and post. And when we get to the next slide.
Now it's interesting that when Charles asked us to do this, we pulled the article out and hadn't read it for a while. And we get together for lunch just about every Tuesday. It's a joke.
Every Tuesday.
It's a joke on Main Street.
35 years. Yeah, in fact, we had lunch on Thursday a couple months ago, and one of Al's employees who came into the office for adjustment, she said, what's going on with you and Al having lunch on Thursday?
We were asked to do many papers for Sorcy over the years. Yeah. This was one that we did. Harvey can explain it.
Well, actually, we, on our own volition, we took 20 patients that we co-treated in the late 80s, and we were in the early 90s now, and studied them with pre and post X-rays and marking systems. And we found really good results with all 20 of them, and that's how we studied them, with those X-ray findings. The one we have up there right now is the one that we wrote the second paper on. And we did all these kind of things where we drew, and then we superimposed the original cervical spine on the present cervical spine and marked it accordingly, and found really that we're onto something.
And the interesting thing about all this is that we were being driven by Sorcy in those days, by the editor for JMPT for material. And we kept looking at ways to try to quantify and publish. It's really difficult when you have two professionals doing different things. How are you going to find a control? It's just really, really hard to publish. But we published many little papers. Harvey's published a lot more. Charles has been a real influence in this organization getting papers published. And there's a lot here to all of this. And our role today is to go back and look at that article. And as we sat there on those Tuesdays reviewing the article, it struck us that everything is about the same. There's one addition, which I'll tell you about, that's changed our thinking a little bit, but primarily the model, the way we manage, and the way we think has not changed. We're certainly better at it. We certainly don't need a lot of communication. We don't need the little brown envelope, but the care and the therapies that we provide are basically the same. We're inside each other's head. Charles had a quote one time, something about our 2 brains were melded together. You talk to Al or Harvey, it's the same thing. That may be so. So the purpose of this review by the original authors is to examine whether those principles as stated in the original papers are still valid today after 20 years. I love this quote, the beginning of knowledge is the discovery of something we do not understand. We didn't understand why we were getting the results we were getting, and we kept looking at it, and we kept trying to find a reason and find an explanation. And Harvey, in his world, was looking for answers, and I, in my world, was looking for answers. And some of the things that I'm going to present today are just for the chiropractors to understand how I got where I was and what the implications are. Harvey's done a tremendous amount of publishing in regards to his field, and let's just talk about this for a second, Harvey.
Well, I mean, okay, we wanted to take this from theory into reality, or theory into practicality, and not just have a theory. That's why we studied those 20 cases very carefully. But the thing is that chiropractic's based on, we'll say, subluxations or structural problems. We called it structural competence. We don't disregard the subluxation theory. To us, it's more than just a theory. It's real. But we didn't disregard it. But we wanted to look at this thing as what influence does craniofacial growth and development have on structural competence throughout the whole body. And that was really the essence. And we even put in the when you read the article that we published in this, that we're addressing today, we put a little, we call it Chart 1, which Al and I had a lot of really fun discussions about. But it's really that I personally think, and it's really helped me in a lot of ways, that if the cranium is not growing and developing properly, and which is what Al's going to explain today, it's going to be structural incompetence. You know, a bad jaw is a bad cranium is a bad spine. And what's the reason that people have it? Because they lifted a heavy trash can? Maybe so. But maybe they were vulnerable. A car accident? Maybe so. But the spine is severely challenged if the cranium is not growing and developing properly, and there's not a reasonable amount of function in the occlusion.
And in this process, in the 90s, and early 80s, I'm looking for an explanation of why it's okay for me to bring the jaw forward, to you as a dentist. Because in 1978, I was taught centric relations, centric occlusion, and I'm bringing these jaws forward and I'm seeing these great results, and I'm trying to find an explanation. Well, when I met the people at Sorcy at the SOT, it gave me the explanation. It tied it together. It tied what I was doing to the whole body. So it gave me, you know, a reason for the corrections that I was seeing. It gave me a reason for the response you see when you treat patients. They come back with symptoms that they don't seem to be related, but you're changing stressors in their body, and now their body's able to function better. So I thought I was a quack. I thought it was some kind of it was a hoax. People got all kinds of things better, and it sounds crazy when you talk about it. So he's looking for a way to help his patients get better, help his adjustments get better. I'm looking for an explanation, and this is what we did, and this is how we do it.
Now, let me just interject this thing I couldn't see before. Desjardins stated, but if the cranial sutural system is off balance, the maxilla system will be off balance, and the category 2 will not hold. And that's basically what we just said. It's a system. It's all intimately related. If you change one, you change the other.
And we talk about, systems. There's people in the chiropractic world, I think of systems as their own little niche about what they do. That's their system. We're adding the whole Maxilla. We're talking about the cranium and the spine and the body as a system and treating it that way. And dental occlusion is a big part of it. And we're not just giving lip service to a physicians of the mouth. And with all due respect to Al Fonder, that's old news, and it's really there's a lot of people after Al Fonder, and they did great things, Weston Price and all those names, those great names that we all rattled around with in the 70s looking for reasons and answers. They were just, it's like the old story about you see an elephant and you blindfold somebody and they, this is an elephant, the trunk, and this is the elephant. We were looking at this big picture. So occlusion and all the things that we talk about in SOT, occlusion is part of it, and the major knew it then. The major talked about it as the black hole. He said dentistry is important, but he didn't know what. He just knew that dentistry was important. And when I met the major, the hair on the back of my neck stood up because I said, this guy needs to know me. I need to know him. It was like, wow, It's terrific stuff.
Yeah, let me just interject one thing here. The thing is that SOT was the perfect method to coordinate with what Al was doing. It's a perfect method. It's all about systems. Categories are systems, systems of the body. Desjardins was a systems man, and the cranium inclusive in that system, obviously. whole body's inclusive. So SOT is we asked the question in that chart 1 in the article, is SOT the right method for these principles? And the answer we got was yes. Was the methods that Al used, which he's going to be talking about, right for these principles? We'll see when he talks about it.
Okay, Harvey.
Yeah, it's just that the chiropractor began to look at spinal subluxations not as a deduced or local event, but as a byproduct of structural deficiencies in other areas, primarily the cranium. So we're not disputing subluxations of the spine. They're there. We talked about that T6 with that gentleman when I was up here before. They're there, T6 thing. But the cranium and the way it develops and grows is an influence on structure, what we call structural competence. That's the word we like.
And
subluxations included.
And this was published in 1994.
Oh.
So the principles of care.
I got to stand closer.
Oh.
There you go, right.
He smells bad. The principles of care. The body is a functional system, not individual random parts acting independently. We monitor functional indicators as a primary method of evaluation. That thing that Harvey, that lecture, that little piece that Harvey did this morning, we continually treat and reevaluate. When I taught at Penn, the residents were taught to create a treatment plan from plan step 1 to step 50 over a 3-year period of treatment. How could you possibly know the effect of step 2 until you look at it and evaluate it? That's what Harvey does with his work. You know, what we used to put in the envelope was patients not doing well. I would go too far, or I would go to this, or I would, and we would back and forth. It's adjusting. It's like a sailboat in going upwind. You're tacking, you're monitoring, you're watching the patient, looking for the response. We're not fixing anybody. We're just making them better. We're making the function better.
Yeah.
And I'll say something now, and I'll say it later when I talk about growth and development. When I first started lecturing to the people at SOTO-USA, I used to say to them, there's any suture in the body, any joint in the body, you folks can adjust with the exception of one. There's one joint, there's one suture you can't fix, and that's the occlusion. And the occlusion is set at the age of 8 and doesn't change unless a dentist gets involved and makes it worse. And that's a truth. That's a truism.
Mm-hmm. And yeah, that's another plug for SOT here. I mean, that's the beauty of SOT. It's all based on functional indicators.
What we do as clinicians is either enhanced or diminished by the person we do it to. And there's a big part in the article, the original article, about the patient's responsibility, the patient's piece to the whole process. Taking responsibility. You know, using removable appliances. If you don't have a patient that wants to do this, it's not going to work. If you don't have a patient that wants to run down to Harvey's office and get adjusted at the same time I'm bringing their jaw forward, it's not going to work. The patient has to buy into the process. They have to be part of the solution. So what I'm going to talk about a little bit is growth and development, and I know this will be boring for the dentist, but just as a review for the chiropractors, I've done this lecture for chiropractors 1,000 times. I was part of the cranial meeting at the SOTO-USA in the early days, right before Mark Pick or after Mark Pick. And the point of understanding growth and development is I want you to understand that the face is a dynamic system changing throughout life, and I have great references to prove it. You know, when I first started involved with craniopathy with the SOTO-USA group, there was this discussion, can you move, do the sutures of the cranium move? The sutures of the cranium have to move physiologically, and I have the proof. I'm the other side of the coin. You know, I attended a conference one time in SOTO-USA, and I was palpating somebody's cranium. I didn't feel Hungatz. I'll tell you, I didn't feel anything. But operationally, treating patients as we do, you see the changes. You know that the sutures have to be patent. And the way the face grows, the early growth site is the cranial vault and the cranial base. So think of the brain. You think of the line above the maxilla, and it attaches to the occiput. That's the cranial base. When I was in graduate school, my master's thesis was on growth and development of the maxilla, and as it relates to cranial base. Who knew that I would be treating patients around that with this guy so many years later? It's an amazing thing. My study was to predict the angle of the cranial base and whether they would be class 2, class 1, or class 3 malocclusions.
If you want to reference this information, it's coming right now. It's in that article, 1994 article. The reference how growth occurs on a timeline. foot out.
Now, the second primary growth site, if you go from age birth to 6, and I'm going to show you this with graphics, the second primary growth site is the mid-face, and that occurs till about the age of 8 or 12, 10 or 12, 10 or 11. The mid-face pretty much stops growing. 90% of the maxillary growth is completed roughly around the age of 12 or 13. And the mandible continues to grow until you're in your 20s, and there's evidence now of facial growth continuing throughout life. You can't have fused sutures and have facial growth. I'll repeat that. You cannot have fused sutures in the cranium if you have a growth process. And I'm going to show you some very good studies in our world that have no impact in dentistry, by the way, but have a lot of impact for chiropractors. So let's talk about facial growth and development. And I'm going to make this brief, and I want you to just sit back and look at the big picture, okay? Because when you look at these pictures, you get scared. This is the tongue, this is the developing, the nasal septum we call it, this is the maxilla. And one of the things you're going to notice as the fetus develops, the mass of tissue disappears and becomes a framework for space. You'll notice here at birth, here at 9 months, you'll see the developing bud. This is for the teeth. This is the developing tooth bud. But you notice how the sinus is opening up. The space is opening up. It's becoming a shell to contain a function. In dentistry, we talk about functional matrix. Melvin Moss, who was not a dentist but a great PhD, just passed away a couple of years ago. He promoted the idea of a functional matrix. To make it simple, a thumb is a functional matrix. If I have a youngster sucking their thumb, they change the growth and development of the face. If you take the thumb out, the development goes more normal because you've altered the matrix. Well, here's a matrix here. The developing tooth bud is the matrix. The airway, the space around the maxilla, the maxillary sinus is a developing space. And as it proceeds, we get to a cross-section of the adult. So here's the orbit, okay? Here's the maxillary sinus and the airways. It's very interesting. We have a patient that we had treated a number of years ago who had a blocked sinus, maxillary sinus. The airway between the nose and the maxillary sinus was collapsed, and she had a collapse. I should show that picture. I didn't think of it until just now. The entire side of her face collapsed because the negative pressure against the sinus, the face collapsed on that one side, pushed the jaw to the other side. And that happened while she was growing. The sinus got blocked. It's called silent sinus syndrome. A couple things happen in silent sinus syndrome. The orbit drops, and the reason most of those patients show up at a physician's office is because their eye becomes very dry because the lid is always pulled down. But that's functional matrix in reverse. Just like a thumb is a good negative functional matrix, that's a negative function. But these spaces here, okay, and in dentistry, one of the interesting things about dentistry is we're not supposed to expand jaws. It's a bad thing. In 1979, when I went to a Strang-Tweed meeting, you put your study models before and after treatment, and they would measure the width of the molars in the back. If you were 1 millimeter expanded, you weren't allowed into the room. In 1978, when I started doing expansion, I did it like this so nobody could see me. You were not allowed in the room. And it's still prevalent in dentistry today, in orthodontics. So you can see that the spaces create the bone. The spaces create the shape, and it's a system. And if I tell you that the width of this maxilla is set at the age of 12, 13, 95% of the width of the maxilla is created at the age of 12, and the mandible is going to continue to grow until you're in your 20s, that's how God created orthodontics. It's a wonderful thing. Because one of the things that happens nutritionally, Weston Price and all those old names we talk about, Al Fonder, they talk about the maxilla not developing correctly for a lot of nutritional reasons, developmental reasons. God only knows what, pollution, who knows why. But one of the things you see consistent, I'm going to show you, poor maxillary development is almost like an etiologic cause for deficient faces. Now you'll see. Here's a maxilla at birth, and here's the maxilla adult. Now see all this bone associated with the teeth? That's the alveolar bone. That's what the alveolar bone that the major was talking about. He talked about alveolar arches, and we had this big discussion for the last month about what the major really meant. I wish he was here. But the interpretation is, did the major mean that the two alveolar arches as they fit together, meaning AKA the bite, was critical? You know, was he saying the same thing I said? Because he found this, I hadn't seen this in years. Major said the same thing I said to you earlier. It's the only suture that you can't change in chiropractic with manipulation, because once the bite's set, the bite's set. So this is all developmental. This bone is all developmental. And there's huge implications in dentistry about periodontal disease and bone loss and implants, and I could go on, and we don't have time to do it. But this process of bone, this alveolar bone, is adapting because of where the teeth are. But what's going on up here? What's all this, all that you guys know better than I do about all those shapes, and that's all development. It's all working. If you don't do craniopathy on a child who's sick and you don't do craniopathy on a growing face, shame on you, because these kids need this stuff. Look at that poor boy that Susan showed earlier. All that distortion in that face. We're not going to fix it. We're not going to fix him. He's not going to be a Mensa maybe when we get done with him, but he's going to be healthier, and he's going to function within that range of health for that child. That's our job. That's our role. So here's the maxilla. Here's the cranial base I referred to. There's sella turcica. Here's the the floor of the top of the maxilla, what we talk about as the floor of the brain. And here's the occiput back here. And Harvey and I, in that little envelope, used to fool around with, I would change incisal guidance. Incisal guidance is how the incisors touch the lower incisors, which is basically the bite position. Invariably, when I would change that, he would see changes in the occiput. Did you ever think, those of you who do craniopathy, and you as a dentist, the only real midline structures are the occipital condyles and the central incisors? Mm-hmm. Everything else is lateral. TM joints are useless. TM joints, silly. They're lateral. They're not important. They're adaptive. The most important thing is, where's the incisors, where's the mandible? And how does it relate to the airway? And how does it relate to the occipital condyles? And he would pick this up, and I'd say, how'd you know that? I'd go back there, I couldn't feel anything. We could spend hours and talk about this, but this is really an interesting article. This was published in 1985. I found this many years ago. It's like a tree falls in the forest. Does it make any noise? The article is published. Maxillary arch is narrow in adult class 2s and class 1s. Class 2s, for you non-dentists, is somebody with an overbite, like the case that Miriam showed. That's a class 2, okay? Untreated maxillary width in class 2s is narrower than maxillary width in class 1s. Does that give you a tip to the etiology? This is the dimensions. I don't want to bore you, but it's about 4 to 7 millimeters, which is the width of a molar on either side. Pretty significant. This is a quick growth chart. If you look here around 8 to 13, somewhere in the middle is 12. Actually, the male maxillary growth pretty much levels out, and females actually get narrower in untreated populations. Pretty interesting. Let's talk about the lower jaw. Here's the mandible at birth. Here's the skull at birth. Look at it. Look at all this development. Remember I told you from birth to 6, this develops pretty much at 6 it's done. Then this has to happen, and then this has to happen. And look at all the motion. And when I talk to dentists about what our job should be treating 6, 7, 8-year-olds, I'm criticized all the time for treating patients too young. Mary and I have a grandson. This kid was so narrow. I mean, his upper maxilla was so narrow. Mary talked him into taking an impression when he was in kindergarten, and we've been through 6 appliances. I mean, he's like a totally different kid. Harvey adjusts him. His ears are better. His whole cranium's better. And look at this. This is interesting. This is birth, 4 years. Look at the progression. This is the adult mandible. And again, look at all the alveolar bone. That's a result of the growth process and the eruption of the teeth. This is the underlying mandible, but you can see all the changes that can be made here. Let's just suppose as those teeth are growing in, I'm pushing one way or another. I can modify all that. I can change all that, and I can change how it relates to the maxilla. If somebody has missing teeth in your practice, somebody comes to you with missing posterior teeth, I guarantee you that the mandible's in the wrong place. You're treating a patient with a missing wheel or a missing tire or something. You got to know how to diagnose these things, because each of these patients are different. So this is a great study. This is really a good study. 163 cases spanning the ages of 17 to 83. In other words, at the age of 17, in a study in the Burlington group, they stopped taking x-rays of the patients. They were doing a growth study. They stopped taking x-rays, and Dr. Barons decided that he would go grab some of these patients that were in their 80s and late 70s. He found 163 patients. This is really significant for all of us, but it's really significant for craniopaths. 163 patients. Growth in the adult is the norm. Pretty significant. You can't have growth in the skull if you don't have patent sutures, open sutures. 95% of the sample showed dimensional change in all areas of the face. Total face height increased 2.8 to 10 millimeters. We measure lower face height in orthodontics by underneath the nose to the bottom of the chin. 2 to 10% increase in facial growth. I discovered a patient one time, he was in his 30s, he brought his models to me. When he had a set of study models taken when he was in his 30s, he came to me when he was in his 40s. He showed me his original study models, and the study models were significantly different. And I said, you've had more growth than normal. He says adults don't grow. He was a endocrinologist. And you remember that story? I said to him, I said, you got something wrong with your pituitary gland. He walked out of my office. I had treated his wife for headaches. She was great. He gave me credit, but he walked away. It must have bothered him. He went back to the hospital, UNC, did his endocrine studies. He had a pituitary tumor. Excessive growth of the mandible. It still grows. It still moves. The face still grows. Total enlargement of the whole face is 2 to 10% on average. These are quotes from the article. Now, this guy is a dentist. He's an orthodontist. He's a big shot. He's a politician. He doesn't have any idea what this means to anybody because he does orthodontics the way he does orthodontics, which is the traditional way. But he published the article. It was a research project. Here's where research didn't match clinic. You got a beautiful piece of information, just like the maxillary width studies, but it doesn't match. Rigid stability of the craniofacial skeleton is an untenable concept. You should put that in your rooms, in your office treatment areas when you're doing craniopathy. Termination of craniofacial growth in adolescence is an erroneous belief. And the only patients that grew poorly were the ones that were treated orthodontically or had missing teeth. The only patients in this sample that showed no cranial growth as an adult were the ones that were treated orthodontically and had missing teeth. Pretty significant, because the orthodontics that was done on those patients involved using headgear to push the jaw back or dental extractions. When I give this to a dental, I don't get invited to speak to orthodontic groups anymore because they can't wait till I retire. Dental groups kind of get it somewhat, but think about that. It's huge. It's huge. The loss of teeth obviously alters the growth of the craniofacial skeleton. So you take a patient you've been treating for a while and they come in for maintenance, not doing all right, and all of a sudden, boom, something's wrong. You got a different cranial finding. If you're paying attention like Harvey does, to get a dental history. I did a presentation for the hospital, University of New Jersey Hospital, headache department a couple years ago. I show all these cases before and after cervical spine changes. And at the end of the lecture, the chairman of the department says, that explains it. I said, what's that? He said, we do an intake form on the new patients coming into the headache clinic. The one consistent finding that's on most of the patients' records is, have you had recent dentistry done? It changes. They have periodontal disease, lose a couple teeth, and then when they put an implant. Now we have implants, they're wonderful things, but you anchor this bolt in somebody's head in the same place the bad tooth that just got knocked out because of physiologic reasons, the bolt's not going to move, the pain's worse. The headache's worse. And it's going to be huge. It's going to be huge. It is huge already. Okay, another study, just in case you don't believe me, 58 untreated patients in their late 40s comparing craniofacial growth changes from late adolescence to adulthood. Significantly growth changes occurred. Mandibular midfacial lengths as well as posterior lower anterior face heights had increased. Continued tooth eruption occurred as well. That's published in 1999. Faces continue to change. There's a dynamic system. Now, picture those pictures of the maxilla I showed you and picture the mandible as it grows. Those same things are changing in the faces that you're treating. Subtle, small, in the adult population. In the adolescent population, there are huge changes because the only thing that's moving is the lower jaw, not the maxilla. And then you take that system and take a couple teeth out, or have trauma and knock a couple teeth out. You're dealing with a different patient, a totally different patient. And this is the amount of growth that you can see. This is superimposition, male and female, the amount of facial changes, growth changes in the adult population. Harvey and I we were always looking for answers of what we are about and why it works. And, we went all the way back to 1892, Wolff's Law. Every change in the form and function of bone is followed by a certain definite changes in their internal architecture and equally definite alteration in their external conformation. If an adolescent child gets caught in a fire and their face gets burned and they get scarred, there's going to be an alteration in facial growth. Okay? If we're adjusting patients and we're doing craniopathy on patients, adult patients, and we do functional orthopedics on those patients, and we look at the post-treatment results at the day we take the brackets off, and then we look at them 2 years later, 4 years later, 6 years later, 8 years. They not only are better from what they came to us for, they're growing and developing differently if they're healthy. If their hormones are right and they're eating properly and they're exercising properly, they actually get better. We had a lady we treated many, many years ago. It was her 20th anniversary of no migraines, and she just popped in to say hello to us. I forget her name. 25. What was her name? You know what I'm talking about. Barbara. All right. So what are all these skeletal things we're talking about? And I'm not going to show you before and after. I got millions of those, and that's not the point. All I want to do is I just want to show you some cases of malocclusion. This is like the one Miriam showed. What do you think as a craniopath that narrow maxilla and retruded mandible is doing to that cranium? And if the person's had extractions, what do you think it would do? And if the person had surgery, what do you think it would do? And how do you treat that adult? Now, that person as an adult is not going to show up in your office. What's going to happen is somebody's going to take those teeth out, make them a denture, and you're not going to know that underneath the structure is that system. So I would argue, and I've done this since I first started teaching at Source in the 1980s, I think you need to know dental diagnosis. I think you need to stand your patients up. I think you need to check the midlines. I think you need to check the bite. I think you need to put cheek retractors or tongue blades in the mouth on the side and look at the width of the maxilla. Every patient that comes into my office, before I put them in a dental chair, I stand them up, bring them through a range of motion that I've learned from the chiropractors, look at the midlines, open and close your mouth, and I try to guess the malocclusion before I look in their mouth. Mary will tell you, she works in the office with me. It's the way I do it. I sit them down and I say, we can help you. I can't fix you. I can help you. I can make you function better. I can make every person in this room who has a malocclusion function better. Not fix, but function better. If it's an 8-year-old child, I can almost fix every 8-year-old child. But not adults. But we're not talking about that. That's not what we're talking about. We're talking about changing function. So that patient presents a particularly unique problem to you. This is another patient. I just threw this in. This is the final result on this case. Look at that face. Would you ever think that person would have that face? It's incredible. You know, even she's probably in her 40s now. Look at this. When you see teeth sticking out like that, right? Those eye teeth popped out like that. You see how they're sticking out like that? Look at that. You see that? That's an indicator. You guys like indicators. It's an indicator that maxilla is too narrow. Right? If the teeth don't fit, it's not that the teeth are too big, because that's what we've traditionally said in dentistry. And I'm going to give you an explanation. It's going to be simple, and maybe I shouldn't get too caustic because this is going to be on YouTube. But that position of those incisors is set at the age of 8 or 9. If that patient's treated by taking this tooth out or pushing these teeth back, either way, that jaw position is going to stay the same. Now, I told you that the maxilla is done growing at the age of 90%, at the age of 12, 13. Mandible continues to grow till you're in your 20s and throughout life. So if we got this person locked into that position and that mandible keeps going backward, what happens to the cranium? Forget the CMJ. The neck, airway, head position, ears. That's what's going on. That's what's going on in your patients. You know, now we have Invisalign. We're going to make the teeth smaller so that they fit. We're still not changing jaw position.
There's some very basic for a chiropractor, and we put that in the article, and it was in the 94 article as well. There's some very basic things you can do. You don't have to be as accomplished as Al is, obviously, in dental diagnosis, but there's some very basic things that you can do to know that that patient's bite relationship is not functioning properly. Midlines, how the canines match up, cross bites. There's some very basic stuff you can look at.
I'm going to show you this. And, you know, every year I used to do the sourcing meetings and I would get phone calls. The girls in the office would always, ladies in the office always laugh because we get phone calls from Timbuktu. You know, do you know an orthodontist in St. Louis Falls or something? No, that's not the point. I'm not trying to drum up orthodontic business for orthodontists or myself or anyone. But I think you need to, you know, Harvey said something this morning that I thought was really interesting. If this patient has this particular finding, then you have to adjust your expectations for that patient. And not beat yourself up and hold the patient reasonable, and maybe think of other ways to manage the case to improve their function.
You certainly don't want to give them false expectations.
Exactly. Here's another. Look at, this is what we call division 2. When you see those teeth sticking out, you see these teeth sticking out like that, that lateral incisor, and you see how straight those teeth are, understand that this is an adolescent, maybe 13, 14. Those central incisors are vertically upright, and that mandible hasn't been able to grow forward since that tooth erupted at the age of 8. Doesn't mean you have to fix it. When I first came to Sorcery, I saw the guys were doing TMJ adjustments. Like, yeah. So, again, it's a diagnostic criteria. Here's another one. Look at that massive overbite. Look at that mandible locked into position. I'm not going to spend too much time. Here's something else. This is a person that has missing anterior contact, an upper jaw, no anterior contact. That's going to wreak havoc on the occiput because there's no guidance in the front. We call it in dentistry, we call that anterior guidance. Anterior guidance is more critical than molar position, in my opinion. Canine position, class 1, cuspid protected rise, midline centered, forget the posterior occlusion. As long as you have it, it doesn't matter. You can adjust it. But you got to have anterior guidance, you have to have correct anterior guidance and canine rise. You have to get that right. And as soon as you get a class 2 canine class 1, the cranium changes its function. I know because I used to get the thing in the brown envelope. If there's anything we need to do, I'll even take a tooth out or trim a bicuspid so that I can get the canine into a class 1 position to get that canine rise the way it holds the mandible, because that's what makes the cranium work. It's critical. It's critical. Deep bite vertical correction, we just did that one. Look at this person. Look at that asymmetry here. Look at that mandible way forward of the lower jaw. Prognathic mandible. Class 3, that's going to be a different kind of a case than you're used to treating. Here's another one. Look at, when you see those canines like that, you know that this is an underdeveloped maxilla. Another boy, here's a Miriam right here. You see that canine? Right there. You see that? You got a patient with lots of problems. You have to get that canine class 1. I don't care how you do it. If you have to extract that premolar, God forbid, if you have the mandible in the right spot and you get the canine class 1, you've treated that patient and the symptoms will change. And he, and these people in the room, will tell you that you did it right because they can feel it. Patient with migraines, look at the incisors leaning back. I mean, all these patients have all kinds of history. It's amazing. Look at this guy. Look at the migraines. Look at the division 2. Think about those, I keep saying this over and over again. The central incisors are positioned at age of 8 and the mandible has to grow around that block. Okay, so we did that. I think we have enough diagnosis. Let me just do this now. The effects of cranial growth, craniofacial growth, and development on structural form. Craniofacial function is the result of a process of growth and development. The bite develops. It doesn't just come. It develops. And if the central incisors are not in the right spot, or if the molars in the back are not in the right spot, the rest of it cascades into disaster. So we can look, we do it 6, 7 years old in the office. We take a panoramic x-ray which shows us the position of all the teeth. We do an evaluation. You'd be amazed how many patients, young patients with TMJ problems. Most of them have ear problems. Most of them airway problems when the jaws are back. You can just go in there at 6, 7, and 8, develop the maxillas, and you just watch the face blossom. You're making huge, huge changes. The head position is primarily a byproduct of craniofacial growth and development. If the mandible can't get into the forward position, the mandible goes posterior. As the mandible goes posterior, what happens to the airway? As the airway gets compressed, what's the person do? Extends their head to breathe. We have these little turtles walking around in our office. Long faces, backward jaw position, earaches, snorting all the time. It's just horrible. And altered head position affects structures throughout the system. I don't know why this is so complicated to dentistry to accept. I don't know why this is complicated for chiropractors who don't do craniopathy to accept the fact that the cranium is part of the body. How could you do chiropractic and not adjust something above atlas? Really? And not look at it? Clinical decisions are guided by the principles of normal craniofacial growth and development. So this is sort of how we function.
That chart is a real good format for chiropractors doing, consultations or having, conversations with patients that you're making a referral. That's a great format. That's why we put it in there, because that's what they have to know. The reason they have back pain, and that's the third article we wrote, and that's why they have neck pain. The second article, that's why they have it, because they didn't meet those criteria right there.
You're supposed to be on this side.
Oh, this side, yes. Yeah. Yeah.
So, principles and methods of care. From a dental perspective, I'm specializing in craniofacial growth and development. You notice, in the early years of my career, I never even put orthodontist on my card because I didn't think I wanted to be known as an orthodontist. I'm a manager of craniofacial growth and development. I do dental diagnosis. I do maxillary expansion, maxillary development, which is really the etiologic agent of what's causing the facial problem, and then mandibular repositioning. My friend, you're on.
Well, as I said before, SOT, systems method of chiropractic inclusive of craniopathy, is an ideal, in our opinion, an ideal matchup. That's the method that we feel matches up with the principles of craniofacial growth and development. There's basic dental diagnosis. We don't have to, like I just said before, we don't have to be the experts in dental diagnosis, but we know it. I know enough to know when it's there. And I know enough that I have to make the referral in order to be successful. I know enough that that patient has to know what I know. See? And you have to do suture. Now we put that malar maxillary adjusting. Here, we're going to have a little talk here about the malar, and that, to me, that's the bone. That understanding the malar, to me, should be step one in broad letters of what you want to learn if you're learning craniopathy. Understand the malar, and that we use the malar in our Tuesday luncheons and our thing, and I would always write about malar, understanding the malar, and you see, as Al said before, one of the things that we got in this commentary that wasn't in the original commentary is asymmetries. Asymmetry of the function of the malar bone is critical, and we used it as language to discuss what I was finding in conjunction with what Al was finding. So I just want to go through some very basic things here on the malar. Dejarnik called the malar the equalizer. Mark Pitt says you take it out of the cranium and dissection, the cranium falls apart. The malar, let's see if I can use this. Okay, the malar frontal deeply serrated, allowing for expansion and motion. That's where it articulates, or the suture articulates with the frontal bone. Malar frontal bone right at the corner of the eyebrow. You can actually probe around at the corner of your eyebrow and you can feel that suture. It's a serrated suture. Excuse me. Okay. Malar sphenoidal, squamosal and sphenoidal overlapping suture where that 2 is. And it's pretty interesting. It actually forms a beveled suture with the sphenoid. Malar bone is pretty interesting. It's actually the most paired medial internal bone in the body. It's also the most paired external bone in the body. When we get out further in the maxillary, the malar zygomatic suture with the temporal bone. So here's a bone that's sort of right in the middle of all the action. Okay, and the malar maxillary serrated and overlapping. Okay, there it is right here. The maxillary bone. I needed to know as much as I could know about this, because as Al was explaining before, it's all about if the cranium's growing and developing, the midline and the midface is growing properly. If you look at the maxilla, as it's expanding and as it's developing, it has a direct effect on the malar bone. So if it was deficient in function, then it was an issue. If it was developing properly through the cranial techniques that we use and the orthodontic treatment, we were on the right path. And here's the number 4 over there, and that's the suture that overlaps with the zygomatic process of the temporal bone, which makes it most interior and, of course, exterior, the most exterior paired bone in the cranium. So I think if you understand the malar, you're understanding cranial function, and you have a great tool in relating to the orthodontics that are being done. It's a critical bone. DeJarnette used it in category 1s in both temporal and frontal adjustments. It's a major sutural area. For me, the suture that we find through sutural range of motion findings is the maxillary malar suture. It's almost there on everybody to some degree, and it's always different unilaterally. Oops. Okay, there it is. DeJarnette stated that the zygomatic malar joints the face and the cranium. It is part of every temporal and frontal intraoral adjustment. It is essential to balance the facial and cranial sutures or structures. We use the zygoma arches in this sutural technique to align the face and skull in one unit of function. Somebody spoke about, I think Scott did, Dr. Walters. That's out of Dr. Walters' book. Serrated sutures, they can expand. All sutures in the body are basically either serrated or overlapping. Tremendous combinations of them throughout the cranium, but all of them are based on expanding. The cranium is an outward growing structure, and that's if the maxilla is compromised in its growth, its lateral growth or anterior growth, obviously it's going to compromise the mandible, but it's also a great diagnostic tool to know that the cranium is not functioning properly, and the front door to get into the cranium is through the malar bone. There's the range of motions. It's a real basic. You just get on both sides of the cranium. You use one hand to try to pull the malar away from the maxilla, just slight teasing pull while you stabilize the head. Almost always, and another thing that I like to do a study of, almost always when one malar is deficient, which is a frequent finding, you almost always see the head pull to one side. In those cases that I showed before, I mentioned the malar was found limited in motion in conjunction with postural findings on the plumb line. Everybody in our office gets put on a plumb line, fixed foot position, and their cranium is looked at on the plumb line. Almost always you see a person's head is going in one direction. It's almost always functionally deficient in a standing position on the side of limitations of the malar ranges of motion. Part of the range of motion, that's another way of sort of supplementary care of the malar. This as well. It's funny, I was looking at this yesterday, I forgot to put in the suture release, suture release is one of DeJarnette's sutural cranial techniques. We use it both diagnostically, another one that we integrate both diagnostics and adjustment. But as you work this suture, almost always, suture release is more restricted on the side of the malar, where the side that malar is compromised in range of motion. Suture release is a system where you go on 6 points along the sutures, malar frontal, malar sphenoid, and you go all the way back 3 spots along the temporal parietal suture. And you'll find restrictions one side compared to the other, almost always consistent with the deficiencies in function of the malar. There's a malar adjustment, one of the adjustments. We do a series of 4 sutural adjustments to enhance the function of malar. That's DeJarnette's, what he called the malar zygoma lift. And it's basically you're just guiding your finger it's a two-handed adjustment. All sutural techniques are two-handed. You're moving the head in a position to maximize, and you're actually opening up the suture as you get that feel of that cranial bone moving. And we're back. Okay.
I just want to add one thing to that malar process.
Yeah, I do too.
Go ahead. When you see a patient with a crossbite, this is a dental crossbite. When you see the upper teeth on one side biting inside the lower teeth on the other side, invariably when there's a crossbite, he always tells me there's a malar problem.
Yeah.
And one of the interesting things, and you really can't see it on this, I just thought of it. In dentistry, when we were taught class 1, class 2, class 3, the positions of the molars, not like categories, it's just the location of the two molars in relationship to each other. The classic positioning of the first molar relative to the lower molar was based on the key ridge, which is on the malar process. And Edward Angle, back at the turn of the, not the last century, the one before that, 1900, said the key ridge was the key. It's the key to the face. You have to get the bite right, the key to the face. He didn't understand expansion because when we expand with the removable appliances, you get alveolar change. When he expanded, he used wires. He tipped the teeth out, much like some of the techniques still, and they tipped the teeth out, and the teeth would collapse because the muscles will pull it back. They didn't change the maxilla. He's always telling me, still got restriction on the right side, Alex. I say, how's so-and-so doing? Still restriction on the right side. Because we got to get that buccal segment in position. That malar bone has to be right.
The malar. And I was talking before about that silent sinus. And you know, when you look at these people with malar deficiencies, you see asymmetry of their maxillary sinuses. And almost always they have a sinus problem. Of course, everybody medically that has a sinus problem has an infection these days. And they immediately tell you have an infection. But that's a side note. But these people with silent sinus, it doesn't mean that one sinus is whole and one sinus is shut off. One side might be whole, the other one might be functioning at 25, 35, 50%.
Now, to be honest, in our review, everything wasn't peaches and cream. There was one thing that we just didn't emphasize as much then as we would today, and that's asymmetries.
Right.
There's no such thing as a symmetrical class 2 malocclusion. They're all asymmetrical, and asymmetry is a big issue. And the interesting thing about doing maxillary development with a removable appliance, when you allow the maxilla to develop the way it's supposed to, the asymmetries literally go away because the body centers itself in a healthy patient.
Right.
And I always say in a healthy patient, because when I'm treating an adult who's not being managed by Harvey, he's not or she is not a healthy patient. In the combined care model, the patient's healthy. So that's the only thing that we, after all these years, emphasize more than we did before with asymmetries. And I know we're getting close to the cocktail hour, whatever happens next. And I want to get to this combined study, this case study. This was a patient that...
Can I just interject?
Yeah.
It's really interesting how we came up with this patient. She was the last adjustment in my office on a Tuesday. Remember Tuesdays? Lunch with Al, Tuesday. And Al came over to my office to meet me for lunch, and she was the last patient. She came out, and Al, of course, greeted her and hugged her, and she had just got her like monthly adjustment in my office. And as we were walking to lunch, we didn't have a case to put in this, not that we didn't have a case, but we didn't choose a case yet to put into this review article. So we said, well, how about her? And we did, and we found some pretty amazing things when we looked, you know, at the details of her case, and that's what we're going to present.
And
right
the reason
now.
the case was so interesting to us because we had CT scans that were done for other reasons, so we had something to back it up.
But if Al didn't walk in and she wasn't walking out.
Exactly, Roma. So here's the deal.
Sorry.
This chart, interestingly enough, what happened? You want your over there. Well, you know the problem is that the screen is. We have to both be able to see the screen.
Yeah.
Now, this chart in the original article, which you see in your packet, I'm sorry, we used this terminology.
Yeah, that's it.
We have a model of co-treatment, and we broke it down into steps. So you'll see it in the article, and we wanted to relate what we did with this patient in terms of all the details and tie it back to the early terminology, which is as good as the existing terminology, but we have both. So the patient showed up. This is the history. The patient showed up. She had seen many dentists. Their recommendation was surgery. She had a dislocated disc, and she presented with a closed lock, and she came in with an MRI that shows a closed lock. I didn't know. I never order the stuff. You just do it clinically. But she showed prior to the surgical office, they found the MRI with a closed lock, and we're going to do the surgery. And at the same time,
it's talking about one diagnosis: pain in the right TMJ, head, neck, and trap. 20-year duration. She had this pain. Her medications were prednisone. I already said the 20-year thing, but that was her history. It's the
So-
history.
Now, we used the term earlier, orientation and evaluation, because it's really important that the patient, the client, we like to call them, when they're in both offices, have a continued experience philosophically. So both staffs are on the same page. We used to do study clubs together with the staff. We used to do retreats together. I mean, our staffs are really plugged into each other. So we call orientation today, we would call it history today, but that's how she presented. And she was very upset and very frustrated and very annoyed and all the things that go along. When I saw her, a closed lock means, in our dental terminology, a closed lock is the condyle is displaced behind the disc, and when they open, they can't get back on the disc. And they open and deviate to that side, typically 20, 24 millimeters, something of that sort. So she had a right closed lock, 24 millimeter opening, deviation to that side. She was a class 2 on the right, which means the dentition was class 2, and class 1 on the right, which is asymmetrical. That's what prompted us to talk about this asymmetry business. And the right maxillary dentition was tipped towards the palate, so the maxilla was very narrow, okay?
She was a category 2. She had altered head position, right cervical restrictions, right leg deficiency, left lower fossa, cranial suture restrictions, right maxillary malar suture, right where the pain was. It wasn't diagnosed because that was the painful side. It was through ranges of motion, cranial ranges of motion. Suture release points on the right, unable to open her mouth on the right side.
So in our 90s terminology, we would say evaluations or systems analysis, meaning we're putting the whole...
Much more formal in those days.
We were really thinking very highly of ourselves. Today we just call it the exam.
Right.
There's the treatment. In my office, and there's a mistake on this date because one of these dates should be 11, but we started with a removable expander because the maxilla was constricted, and as we did the expansion, the mandible, she recaptured as soon as we did the expansion. We expanded the maxilla, the mandible recentered itself because she was being managed by Harvey. Interestingly enough, she had a dental issue. There was a tooth that was traumatized and she had lost some tissue. So now that we're getting her comfortable and I'm looking ahead at the aesthetics because I know I'm going to have to deal. Every patient becomes an aesthetic patient. Every pain patient becomes an aesthetic patient at the other end of the process. And I knew I was going to have to deal with this central incisor, so I sent her to a prosthodontist that I work with for a CBCT, cone beam CT. Well, we had a cone beam CT, and part of the analysis, you send it away to a radiologist, and they reviewed the TM joint. And at that early point, there were no abnormalities in the TM joint. She had a range of motion already that was normal.
So that's about
And that was
4 months.
Yeah, that's 311, no, not 310. I can't believe we missed that.
Okay, so that's 4 months.
Right. At that point, I put the fixed braces on. I was torquing the incisors. I did a second expander just to make sure we had enough expansion. We did vertical mechanics. You know, you do it with the block. That's one of the reasons I don't do the block is because I don't think it can control the vertical as well. We can talk about it afterwards, but vertical mechanics are crucial. If you're bringing the mandible downward and forward, particularly with a closed lock, you have a deficiency in vertical dimension on one side, not the other. So with bite plates, you can actually control the vertical and vertical elastics, yeah. Braces were removed and anterior bite appliance for maintenance. And then...
Well, you know, up until that point, over those 4 months, she's really wonderful person, and you always would say, I would say, how you doing? And she'd say, I'm still on the ledge. That was her comment, meaning that she still was ready to jump, but she was better. But anyway, category 2 blocking, trap fiber number 6, thoracic gate adjustment off the trap fiber, cervical stair step, figure 8, sutural technique, mostly right maxillary malar, and that suture release technique, which is, again, both diagnostic and an adjustment and therapeutic. Home care, give her some things that she had to do for her cervical spine, sleeping position, computer, TV, adjustments, and head righted.
Now, in the early model, we talked about preliminary pain relief and intermediate care going to maximum function, and that we kind of broke it down, and in some ways I still think of it that way in my office, because if a patient comes into my office and they're in acute needs, okay, we're going to get them started with an appliance that may or may not include a splint, okay, but we're going to start. Depending how they respond to the first couple of adjustments in Harvey's office, I'll decide whether I use a splint or not. But that's sort of what we care, like the beginning preliminary care. I want them to buy into the process. I want them to stay with Harvey. I want them to know that that's part of the process of our care. And then as we start that we get past that phase, now they're into it, and now they're turning the screws or they're wearing the braces. So we sort of blend from preliminary pain relief into intermediate care to get the correction that we want.
I just want to emphasize there, I mean, the most critical thing in that whole graph there is that she went from an MRI closed lock to a cone beam scan that indicated no TMG abnormalities in a four-month period of time. Pretty remarkable.
And we don't normally take
remarkable.
post-treatment records because that's why you can't publish it. Somebody got to get a CBCT
Until we
done.
started investigating this,
Yeah.
we didn't even really know that we had this in our records.
So we called this in the original wellness care, the outcome, the dental outcome was a 50% reduction in overbite. And I purposely didn't bring the models. I thought we had enough data here to show you, but I wanted to keep it more chiropractic rather than dental. 50% reduction in overbite, jaw opening 45 millimeters with no deviation, with no pain, significantly improved dental occlusion. There's a misprint there, my goodness. Chiropractic through the period.
It's because she came in on Mary's birthday, that's why.
Yeah, exactly. Your birthday. Mary and Harvey share the same exact date, birthday,
I know
city.
she looks a lot better than me, but we're the
Same city.
Same birthday.
Same day, exact
Same
day. Same year. Harvey, you can go through this a little bit?
Yeah, well, I mean, she did real well. We basically did all the initial adjustments through 1/16/11 till 3/26. No limitations in translation of the right TM joint, meaning, from my perspective, meaning she could comfortably open her mouth. Complete relief, no meds, and improvement in all findings. And now being adjusted about once a month. And she comes in. We still find some things, and we even put it in the graph. But as far as her findings, again, she's functioning so much better in the right side of her cranium in so many different ways that she doesn't stand on a plumb line anymore with her head righted.
Before she started treatment, her husband is an editor for WebMD. So when I presented the treatment and Harvey presented the treatment, there was all this discussion, is this really going to work? Should I not do the surgery? And as an aside, can you imagine that case being treated surgically now after what kind of results we got? But she's in the car, she's talking to me, and her husband is asking her to ask me these questions. You know, strictly medical model. I mean, we had to fight the husband who never showed up, never came to the office. But we had to fight the husband to get her to accept treatment. She finally accepted treatment. I ended up treating 2 of her kids as well. We got great results. But you're fighting the establishment.
But I mean, this is a relative statement. I mean, it took a couple months to really, for her to get off the ledge.
Yeah.
So it took a couple months. So it wasn't, we put a comment that I dug up, Einstein's comment, the reason for time is so that everything doesn't happen at once. So, that meaning that I think as chiropractors, we got to be, this is changing structures, changing function. Give it a little time. This is only 3-4 months.
So as we stated in 1994, this model of care featured a high integration between the chiropractor and the functional orthodontist and assumes an intrinsic connection between facial growth and development and structural competence. This is from Bill James, the baseball statistician. We shouldn't be too confident about the things we think we know. As stated in the original article, our purpose is not to present formal research results, but to present an alternative approach to patient management, and one that has proven successful for the authors even 20 years later. This is Harvey in what year?
This is in the...
This is a surprise. Chiropractor of the Year. And there's our...
Hang around long enough.
There's our cadre of some of our mafia. And there's Harvey and I after we got drunk when he was Chiropractor of the Year.
We take this very serious, this one.
Thank you very much. It's a long presentation. I thank you for your attention and interest.
Yeah. You want us to do the questions now?
Yeah.
If there's any questions or comments?
I have a question. I don't know if that's should be said. What is your input on ALF appliance alpha? Just want to know.
We have a history about that appliance, and I'll go into it later. It doesn't matter what you use. You know, I had a professor that taught me a long time ago. He used to say, Chinappi, he says, if you can use a bobby pin and a piece of dental floss and move the teeth to the right position, you move them to the right position. There's a quote that's in the article, I think it's in the article in this review. Mort Amsterdam, the ex-chairman of our department, used to say, there's one diagnosis but many treatment plans. I don't care what you use. It doesn't really matter. As long as you expand the bone of the alveolus, okay, you can, whatever braces you use, the brace. Our profession is into this technology, the Damon and this bracket and that bracket. It's nonsense. It's all nonsense. It's diagnosis, diagnosis, diagnosis.
Well, the reason I ask is because I don't use it often, and I was at one of the seminars that I was, and there was a couple of people like Dr. Blum, SOTs, and they asked me to use ALF, and they said that that's the best thing to use to be able to get all the sutures opened up, and the other appliances won't work as much. And I thought, am I behind this? Because I've not, 21 years, I don't use ALF.
You use a Schwarz appliance, you use a three-way appliance, you're going to develop the maxilla. If you have enough savvy with the fixed appliances, you get the braces, get the Canines class 1. It isn't that complicated. It's diagnosis, diagnosis, diagnosis. The appliances are academic.
So Dr. Harvey.
Yes.
Yes. Did I say it right, Dr. Harvey?
Yes.
So from your standpoint, if we use the Schwarz or not, you know, I just want to make sure I'm mentally comfortable with this. I'm not closing down the sutures and tightening up because the appliance turns and then it stays stable for a while and it's basically holding the arches that way. That's not going to go against what you do, right?
Well, let me just read.
There's a lot of stuff out there, and I just want to.
You're asking a really good question, and I want to address it too.
I just want to say, read this that we put in the article, and it's the essence of this chart number 1, which Al and I have had a lot of fun discussing over the last year, by Ralph Waldo Emerson. I think this is very applicable to chiropractors, certainly. The man who grasps principles can successfully select his own methods. The man who tries methods ignoring principles is sure to be lost. See?
I've worked
and
with...
that's what Al said. Use bubble gum and a bobby pin. If it gets the maxilla to where it should be, so the mandible can develop.
You know, I've worked with chiropractors who like to do AK, and I've had wars over the years. Put the appliance in, turn the screw, they muscle test the patient, and the patient's weak. Take the appliance out. Hey, I'm challenging the system. I got to challenge the system to make a change. Your job is to keep the patient comfortable while I'm doing it. You know, this nonsense of this appliance moves that suture and that appliance moves that suture, it's nonsense. I'm just telling you
That's
it's
why
nonsense.
the Malar was so important.
Yeah.
That's what we needed to do.
I just feel that
Since my name was mentioned.
Yes, yes, Charles.
Oh, you're Charles Bell.
I don't know what the option was.
I found with many patients, they prefer an ALF over because of what you're saying. There's more tension involved in some of the procedures.
That's why.
However, it has to do with how the patient responds. If they respond well, it does not matter.
I respectfully disagree. It's not about how the patient responds, it's how the doctor responds to the patient. Okay? What's the difference if you have an ALF in there or a Schwarz appliance or a sagittal three-way, whatever. Whatever you put in there is foreign to them. What you have to do is give them the concept of what you're trying to accomplish. They'll buy into it, you know?
I've just found that some patients have a preference, and that preference dictates whether they'll comply.
That's fine. I'm okay with it. But I don't know that the ALF does anything significantly different to the sutural systems.
Oh, no,
Yeah, well, that was the question.
Okay.
That was the question. I mean, is there a magic wand to the maxillo-pterygoid maxillary suture, or, you know, it's
I just find that it depends. Some patients it doesn't matter.
I'm going to say something. I say something to the patients all the time. When we put an expansion appliance in, I say, this is the bulldozer. Okay? Now, Harvey's going to keep you comfortable while I'm using the bulldozer. But I got to use the bulldozer. Okay? And the first couple turns, you know, I remember I expanded my own maxilla. I put that puppy in there and I did the first couple turns. I felt like my head was going to explode. Whoa, this thing really does stuff to you. You know, I treated my wife. I've treated thousands of patients. They've all had magic with this appliance. This appliance is terrific. I have an article published in, you referenced it, I think, in Inside Dentistry.
Yeah.
Yes.
Go on Inside Dentistry, look for my name, And there's an article I published in Inside Dentistry, and there's an interesting case that I presented. I
Yeah,
think
it
it's
is.
in there.
Yeah, it is.
Yeah. Inside Dentistry, reference my name. It goes back about a year and a half, and there'll be.
It's in the book.
Yeah.
Is it drawings in the book?
Yes.
Oh, what's in
It's
there?
in the
Okay.
book. The article's in the book.
Charles, you're the man. Charles, you're the man. You and Charles Barkley, I love it, man. You guys are the man.
You say bip, I say
Oh, that's good stuff. Yeah, in the article. Read the article, and you'll see all the cervical. Just one patient cervical change. I mean, it's just incredible. But go ahead.
For me, when I'm comfortable with an appliance that works for me, I like to stick with it. And there's always people come and tell me, you know, use this bracket. This bracket's working for me. I'm getting the result I want. But when I want to start working with other interdisciplinary people, I just don't want them to think that there's other things that I need to go learn about it, or can I just stick with what I have? I just wanted to make sure that's not affecting.
You know, this whole concept of the maxilla, an appliance in there, you know, locks the maxilla down and creates. I don't find that. We don't. You know, I'll start doing expansion and put braces on this in a division 2. I put the braces on and flip the teeth out of the way. That idea, you're stopping the maxilla, the premaxillaries, that's just nonsense. That's not the way. It's just not the way it works out.
Page 67.
Great question.